Okay, guys, we're going to talk about addiction, and for the sake of our mental illness unit, we are also going to be calling it by its name as it stands in the DSM 5, which is substance use disorder. So those can be used interchangeably. Let's talk about our culprits here. We're going to be using our opiates, and these are either prescription or non prescription opiates or opioids. Opioid is the lab created opiate, and then opiate is straight from the poppy plant there. What it does in our brain is it activates the mu opioid receptors. So we have these receptor sites that are hanging out at our dendrites, and one of them is specifically for the capture of these opiates, and that's the mu receptor. Then we have our stimulant, which is our cocaine or methamphetamines, things like that. They work on quite a few of our receptor sites, dopamine, serotonin, and norepinephrine reuptake transporting. Then we have our nicotine, which it acts on our acetylcholine receptors, and nicotine is that molecule found in the tobacco plant. Our sedatives, such as alcohol, benzodiazepine, and barbiturates, are going to be working on that GABA receptor site. So it's going to quiet that excitability. That's our inhibitory neurotransmitter or hormone, if you guys remember from that neuro overview. Then we have our marijuana, which is has a specific receptor site called the cannabinoid receptor site. There's some other commonly used drugs that are likely to be abused, and these include ecstasy, hallucinogen, peyote, magic mushrooms, things like that, our K2 or our spice, and then our cough medicine. We'll talk about a little bit more about those in your emergency medicine theory class that you'll have with me at the end of the year. Well, you'll be like that much closer to graduation. Oh, so very close. So addictive drugs act by binding to specific proteins in the brain, and obviously they disrupt their normal function, and some can be agonists, so they bind straight onto that receptor site and don't let go, and then some are inhibitors, which means they block the transporter function. Like, for an example of that is the dopamine reuptake, so it blocks that ability to reuptake, making it the dopamine more available to the next receptor site. So if you guys were guessing people, how would you define addiction or substance use disorder? And the answer to this is going to be, of course, none of the above. And we will definitely go into the DSM 5 criteria for substance use disorder. They basically will narrow it down to a mild disorder, a moderate disorder, and a severe disorder, aka the addiction, if the person meets 6 of the following 11 criteria. And we won't go into this too much because you guys have eyes and can read, but basically we're going to be in hazardous situations. It's affecting our functioning there. We're using, despite the fact that we know that it's something that we need to cut back on or control, and we have this like craving or strong desire there. So that sounds an awful lot like a chocolate addiction for those who love chocolate. But if you go back into our DSM 5 criteria, I bet you are not getting yourself into a hazardous situation and the like by getting your hands on the chocolate. And we need oxygen every day to breathe, and with every breath we take, right? So are we addicted to oxygen? And once again, according to that DSM 5 criteria, we are likely not addicted to oxygen. So is drug addiction a disease or a choice? And this is something that's hotly debated, and you're really going to have to come up with the answer on your own. But as the evidence shows, we're going to go ahead and say that a mild substance use disorder is likely a choice. Having said that, a severe substance use disorder is likely not a choice. and how you think about this is going to really affect your countertransference, right? Your care for the patient. And here, once again, just that DSM-5 criteria. So we are in a current opioid crisis. People are dying all the time, every day, due to respiratory depression at phenomenal rates. The causes of this are complex, but this doesn't happen to be the first opioid crisis. There happens to be a couple of them in history. If you know the history of here, even in the United States in the late 1800s, we had quite a few people that were pretty addicted to morphine, and so heroin was created to get these people off of morphine, and you can see what happens with heroin. So there's been a kind of terrible history there. But why are we in our current crisis? Lots of different reasons, but here's a few of them. We have this aggressive marketing by drug companies that minimize the risk. In fact, if research is done and sponsored by these drug companies and there's something in that research that is untoward, they will just simply not make the research available. So you really have to look when you are doing your own peer-reviewed studies and researches that it is not sponsored by a drug company, which can skew some of the numbers there. And then we have an overprescription of opioid analgesics by providers that are treating acute pain. So our biggest culprits for prescribers are going to be our surgeons and our dentists, and they're the ones that are treating more or less that acute pain there. So there's a tendency for these providers to underappreciate the risk of abuse, and they just simply need more education there. And then once again, there's kind of just like this lack of good alternative options to treat pain. They're out there, but it does a really good job of treating pain. And then there's an import of very heavy, potent fentanyl used to kind of spike heroin. It's also being used on its own right now. They call it Mexies or blues because they're literally blue. Every once in a while here in the Tri-Cities, we get this really terrible batch of it, which typically has more drug in it than people think. And it leads to like all sorts of overdoses. So I think we had, the last time we had this happen, I think there was 5 local deaths because of this. So it's just kind of a really terrible thing. And this is here locally. It is happening. And with those, you can eat them or smoke them or inject them. Lots of routes. So we know that the risk of opioid use is about 10 to 20%. It's not universal. So people differ in their risk, but predicting who's vulnerable is going to be hard. There is some kind of genetic information out there that says, you know, if you have that addictive gene, you're going to be more likely to end up with a substance use disorder than the rest of the population. Maybe knowing that arms people with good resources on staying away from it, and maybe it gives people some leeway within their own brain to think, oh, well, my brain is meant for it, I should be just doing that. So lots of kind of ethical decision making when it comes to these genetic type testing, which is really interesting. So here's our agonist, our partial agonist, our antagonist, and our peripheral restricted agonist. What we do know is the route of use changes pharmacokinetics, whether we're injecting it right into the vein, we're smoking it, or we're ingesting it. So our big agonists that bind right to that receptor site is going to be our morphine, our fentanyl, oxycodone, methadone, and heroin. Our partial agonist, oh, by the way, these all go with like a morphine calculator. So they're all rated based on morphine, 1 milligrams of morphine. So fentanyl, or what is one that okay, so oxycodone, I do believe is 1 milligram of oxycodone is equivalent to 1/10 of a milligram of morphine. So I can actually put a link up there that will show you that kind of morphine conversion chart, and see how these things hold up against morphine there. But our partial agonist, or one's going to be partially binding to the receptor sites, are going to be our little kind of less strong drugs, are codeine, hydrocodone, tramadol, and buprenorphine, excuse me. Then we have our antagonist, which is going to be our naloxone and our naltrexone, otherwise known as Narcan. Little side note on Narcan, they're in the state of Washington, the pharmacists have a standing order to give Narcan at their discretion. So if you go into a pharmacy and say, hey, I'm a nursing student and my neighbor is a known heroin user and it would just be really nice if I had the ability to have Narcan, they should be able to give it to you. We used to give it away as like take-home packs in the ER. We don't do any take-home packs anymore. Apparently they were hard to find charges on or something like that. All had to do with money. And then we have our peripherally restricted agonist, and that is going to be our loperamide, also known as Imodium. So morphine, as we well good know, decreases motility and causes constipation, and our peripherally restricted agonist is just going to do that in the gut. Having said that, high doses, like 160 milligrams or so, of Imodium is going to get a person high. And I hate to be the person that actually tries that out, because they're going to be dealing with some constipation issues. So this is what happens when we take morphine. Hopefully, which is why we use it, is a person will have some analgesia. They're going to have some relief from their pain. That receptor site's going to bind, and we're going to care less, basically, about our pain. The patient might also be sedated, which, can also be helpful. We like to use that a little bit. This might help you take a nap in between the pain there. Like we had reported, they're going to have constipation, respiratory depression as well. We'll find out in the next slide that they don't always happen at the same pace, so we won't get an analgesia before we get respiratory depression. Sometimes that happens at different rates. Patient might also have nausea or vomiting. They might have itching or pruritus, urinary retention. We'll go over that in the next slide. Some endocrine regulatory effects. They might have hyperalgesia, so too much of the good thing, right? And then tolerance and physical dependence. They might also have euphoria, which is a really great side effect for many people, but it also gets them so they're wanting to go ahead and try that again. And then ultimately addiction, or that substance use disorder. So morphine on the mu receptors, it decreases that intestinal peristalsis, that thing that kind of keeps our gut moving along. In addition, it also inhibits GI secretion, so we're not going to be having as much lubrication to move things down, and we're going to also slow the gut as well. And as it works on our smooth muscles, it will contract sometimes our biliary smooth muscle. It increases ureteral and bladder sphincter tone, which causes that urinary retention. And then it'll cause some meiosis, aka your pupillary constriction. So people on these medications will have pinpoint pupils or small pupils. Sometimes they're not very reactive to that light. And then as far as respiratory depression goes, that's the cause usually of the overdose death on this patient, is their lack that drive to breathe. So they're basically their brainstem, which senses CO2 and causes us normally to take bigger and faster breaths, has been inhibited. So we tend to breathe nice and shallow and nice and slow for these people. So opioids are effective for acute pain, but they can cause hyperalgesia, or that experience that we're having a better time than we deserve. And this can lead to the tolerance and dependence. So at the end of the day, our receptors have just become desensitized and will adapt to the nervous system to restore homeostasis, and we ended up needing more of the drug for a lesser effect there. More effect on, or I'll give you a little sheet here in a second about what your rebound withdrawal is going to look like, but basically all the things that you're going to have when you take the drug, you're going to turn around and have the exact opposite. So where heroin will make you nice, or an opioid will make you nice and calm and happy and decrease that GI secretions, you're going to kind of have the exact opposite effect there. And then we have like our euphoria. This is where an opioid indirectly stimulates the reward circuits in the brain. This then leads to compulsive drug use and difficulty in maintaining abstinence. More of all the ways to say the same thing. So our opioid withdrawal then, like I said, basically the exact opposite of what the heroin is going to do to the person. So they're, instead of having pinpoint pupils, their pupils are going to be nice and huge. They're going to have a fast heart rate. They're going to have goosebumps, abdominal pain, muscle cramps, lots of typically like vomiting and diarrhea, and then they're also going to be able to urinate because there's no urinary retention. Okay, I happen to be a visual learner. I hope you guys are too, but I wanted to tell you a little bit about how drug dependence kind of works. So we will be kind of like in our normal state of affairs here. Okay, sorry, a couple of small distractions here. So as we go through our drug dependence, we will kind of start off in this normal phase, and once we take a drug such as an opioid or heroin, either or, we will have this amazing first experience where we're going to have this euphoria, and all of a sudden everything in life has come together, and our worries are behind us. Then as we kind of come down in between drug doses, we're still kind of at this heightened effect, but it doesn't take very many doses for us to figure out that we have not gone back to our normal state. As you can see with these big dips here, we're down into a depressed or anxious or dysphoric state there pretty quickly. And as we continue taking the same amount of medication, we're just barely able to achieve kind of our normal status there. So this is what dependence looks like. And then potentially, let's say that we're going to quit cold turkey, so all of a sudden we have like all these really crappy withdrawal symptoms there, and then we are in a heightened state of dysphoria. But as time passes, generally about 10 days, we go through this period where we kind of return to normalcy, and very slowly. So look at this, between days 20 to 200 is when we'll kind of reach our midline, our normal state. So this is where the neuroplasticity in our brain takes over, and we, as long as we are not taking the medication of opioid, we will usually kind of bounce ourselves right back to normal, which is a really great thing. And then let's just say that there was a life stressor, and now instead of getting our hands on a therapeutic opioid or oxycodone or something like that, then we're finding ourselves on the streets going and getting ourselves some heroin. So we've injected some heroin, and as you can see, we just get these little tight relapses there, and even though we're still using the medication or the drug, we're just like down to, in between times, we just have to use the heroin to maintain some sort of normalcy. So I thought this was a really good description of what kind of that dependence sort of looks like. Just a little bit about neonatal opioid withdrawal syndrome. This is typically a thing that our little NICU nurses are going to see. It's different than fetal alcohol syndrome, which carries its own like specific long-term side effects, but the kind of full research on this says that we don't typically have these really terrible side effects long-term with these guys, but they are kind of hit and miss when they're born. We typically have to wean them off of the drug. So what we know about risks of developing opioid use disorder, we know that over 100 people a day are dying from opioid overdose in the United States, and many are using multiple substances, such as if we mix anything with benzodiazepines, we tend to have a real ill fate with our opioids, because this further reduces or enacts that respiratory depression there. High doses and long duration of the drug increases the risk of developing this opioid use disorder. We do know that we are in need of some chronic pain therapies that people are going to be able to get their hands on, and really they are making some great headway with those. You'll talk about them in 235 lab, but it's just not as readily as available as we'd like. There's more effective treatments. We talked about a little bit about our polytherapy there for comorbid anxiety and depression. So not just our medications of opioids is going to help that. Better understanding of genetic risk factors or underlying drug addiction. So like I said, we're kind of at that stage of knowing, but what to do with that knowledge is going to be a matter of bioethics there. So what controls a risk for developing opioid use disorder? It's not really predicted or predictable, except for people with a history of abuse. So if you have a history of substance use, we can probably fairly guess pretty well that you are going to have a substance use problem in the future if you're given the chance to do so. Then there might be some like absence of socially protective environmental features, such as isolation, homelessness, and things like that. There is that genetic component, that potential for you to be genetically inclined towards risk-taking traits or impulsivity. You might also have an increased risk because of the comorbid depression disorders, and this is oftentimes like across the board with mental health disorders. Especially like our schizophrenia patients, they kind of want to, their thoughts become a little bit more organized. They feel a lot of like shame and defeat, so they'll use opioids as a means of coping and self-medicating there. Increased by stress vulnerability, how well of copers are we, and then interactions with chronic pain syndromes there. So treatment options for these is methadone. That's a long-acting agonist, but it's used to prevent relapse. So this will be like the whole like lesser of two evils type thing, is going to be our methadone. Buprenorphine is a weak agonist, and it's an antagonist against a specific kappa receptor. Our naltrexone is our extended release Narcan, and our naloxone is our short-acting Narcan, and those both go right up on that mu receptor and will block the opioid from actually happening. So when a person takes a medication called Suboxone, they will take the buprenorphine, which is that weak partial agonist, but then it also contains naloxone in it. So people are unable to have respiratory depression. They basically can't overdose because those two conflicting things are going on at the same time. Then we have our, for our nicotine addictions or use disorder, we have our patches or gum. We also have Wellbutrin that we can use, or an atypical antidepressant, or like a norepinephrine or dopamine reuptake inhibitor. Chantix seems to work really well. It's a high affinity partial agonist is what it is. And then for our alcohol, which we'll talk a little bit more about later, we oftentimes use carbamazepine, which is also known as Librium or benzodiazepine. There's been some studies out that show naltrexone, or that long-acting mu receptor agonist, or antagonist, excuse me, works really well for our alcohol withdrawal, as well as this acamprosate, which is a glutamate receptor antagonist and a GABA receptor. So it still makes us feel well and can make you feel really, really crappy when you take it with alcohol. So let's switch gears to substance use disorder among health professionals. And basically we need to kind of treat our peers with respect that they have earned on this. And we need to have support programs for these type of people, but we should always know that our peers are as at risk as the general public at getting a substance use disorder. It's definitely not from a moral deficit or lack of willpower. Obviously, we know substance use disorder is that primary chronic progressive disease. If we can assimilate it to diabetes and arthritis, just like we had talked about in our previous lectures, where it's really easy to diagnose somebody with these kind of things, but for some reason a little bit more difficult to diagnose them with a substance use disorder. A lot of taboos associated with that. It can be treated successfully and we're protected, ADA protective. So the neuroplasticity is a reorganization of the brain circuitry in an effort to adapt to a changing environment. So this is a bad thing for chronic substance users because we are kind of continuously had changed that circuitry in our brain to adapt to drugs. But as we get into recovery, we have realized then that now we have the neuroplasticity in our brain to make us, to reorganize us through recovery. So among healthcare professionals, we have a slightly higher rate of prescription drug abuse, whether we have sweet-talked doctors into or provide prescribers into prescribing these drugs for us, or however that came about. We do have a slightly higher rate of prescription drug abuse than the general population. The American Nurses Association estimates that 6 to 10% of nurses are thought to have substance use abuse problems. That's significant to impair their practice at some time in their career. Okay, there's some occupational hazards that come along with being a healthcare worker, such as yourself and myself. These are role strains, high stress, shift work. We're often working our burning the midnight oil or working some kind of shift work there. We all have a high drive to achieve. We all seem to be a little bit on the type A or anxious bunch. When I first started teaching, my boss in the ER says, how are the students? How are you enjoying teaching? And I was like, wow, there's a lot of anxiousness. But that just kind of seems to be part and parcel with the majority of nurses and nursing students. Then we have potential for chronic pain. We're lifting patients all the time. Patients are assaulting us, so we get injuries that we're dealing with. So we might also have chronic pain. Then there's the problem of access, which happens when we have our hands, our hands on Pyxis and stuff like that. And then there's sometimes lack of education or private policies. We'll have that, unwritten code there where we don't potentially rat the other person out or something like that. So typical, the disease continuum, typically the workplace is the last place that the substance use manifests itself. So this is traditionally a long-standing problem before we'll actually see it in the workplace. Disruptions in family, personal health, and social life occur while the workplace remains unaffected. And then, like I said, the last thing you'll see is problems at work. So in that regard, even small intrusions into the workplace should be taken very seriously. So here's some potential signs of that your coworker might be using or abusing substances. They tend to be like the best worker, like they'll arrive early, stay late, take out the sharps containers, all of that kind of thing. You might notice some increased isolation in this person. You might notice mood swings or practice errors. They might be defensive. There might be some count discrepancies when you do the final count with the medication review there. And they can sometimes take a patient that is in need of high PRN pain medications. So they have access to those PRN pain medications. And with that, the patient will then report lack of pain relief. So diversion is what happens when we transfer the medication from a lawful to an unlawful channel. And this is also known or otherwise is when the legal supply chain of a prescription drug is broken. And diversion is also any criminal act involving a prescription drug. Common drugs that can be diverted shouldn't come as any surprise to you. Where diversion occurs, let's basically just call it anywhere that medications are present. Private homes, it can happen, when we're doing at-home care or hospice care there. We also have at the pharmacies and the nursing homes, at the waste stream, ways that a person, a healthcare worker can divert. They can substitute one medication for another while keeping one for themselves. They will remove medications without orders. They might override medications. You'll see that in like the Pyxis or the medication administration, where you have the potential to override. You shouldn't without an order. They might be giving less than the high end ordered and then diverting the waste. I've seen this personally happen in my practice. I've seen a lot of these actually. And then a person might give a false signature or use like a RX pad for falsification, or they may salvage from waste containers. Diverters, just like we had spoke about a little bit, they might be a bright person, high achiever, ambitious, respected, skilled. They might have significant stress in their personal life. They might have medical issues requiring pain medications, and then a history of drug misuse. So this happens to have come out of the trunk of a nurse who was diverting drugs, and none of these were prescriptions that belonged to her. So this is a big exaggeration of how that can happen. Then we have here a falsified document. So in our 1996, this was to the right, this was written by a physician that ordered some Valium for the patient. And you can see how very close they are similar, but this one in 1997 had been falsified. So wow, somebody took a lot of time to make sure it looked like it was supposed to, huh? Then we can have occurrences such as this, where a person will take out the fentanyl but not destroy the vial there, and then reattach it. So the next, or reattach it and place a fluid in it. So the next person that uses it won't have the drug with them. They won't be giving the drug, I should say. So we should do a lot in the way of prevention to even prevent all of these things from happening. The healthcare workers should know that there's some clear and non-punitive policies. The administration themselves should be implementing and creating these policies. There should be staff education, documentation. We should report observations, but do not jump to any kind of conclusions. And we should have planned intervention strategies. So a just culture means that we are going to try to be making things better for everybody instead of really putting some punitive action on the substance use disorder abuser there. We got to remember that that's not a moral deficiency or a lack of willpower. We can use our employee assistance program for monitoring. We ask ourselves, how did this happen, and how we can change our policies or implementation to make it harder for the next person to be able to get those drugs. And then we have to ask ourselves what structural changes can be made to prevent future occurrences. So, in other words, we should not be putting, things in an open Pyxis. If we take out like a Tylenol, we should not also have access to oxycodone. And mistakes like that have been made. We just work with, implement new procedures there. So all unprofessional conduct is required to be reporting to the licensing authority. So once again, we just have to mandatory report everything, right? Most states allow reporting directly to the approved substance abuse monitoring program. So I talked about this kind of like conspiracy or code of silence. Why on earth would we not say anything? And this is, lots of different reasons. We fear retribution. We're in denial about this. We don't want to get our friend in trouble. You might simply just not want to get involved or face any kind of legal action. So some barriers to know about that. Oh, but they have really great substance use monitoring programs out there. And the state of Washington especially does a really good job. They'll have early identification and entry into treatment. It protects the public and allows nurses to avoid discipline and the attached stigma. So with these, there's quite a few of them. Washington Health Professional Services. Keep going. Okay. And so with these programs, they will create an individualized contract agreement. There's treatment and aftercare monitoring, which means that the nurse or healthcare worker will go through this treatment, and then they will not just be thrown back out to the wolves, but they'll have this aftercare monitoring. And in some instances, we will have the nurse not have access to an opioid in the Pyxis. They have to ask their friends for that. And then they do some weekly or even bi-weekly urine drug screenings and things like that. Okay, so that's the regular random observed drug screens. They'll have a verified support group attendance, so they have to go to support group. So lots of things that we have to do, which is going to better yourself. And then they'll get regular reports from their self, their supervisor, their prescriber, and their therapist. This usually goes on for about 1 to 5 years. And like I said, they have to be drug tested. So most clients are required to attend a peer support group. And there's some issues that can help them, and they don't have to go it alone. So there other people in the group might know the answers to maybe how they inform potential employers about their involvement in that program, how to deal with the stigma of chemical dependence, taking control of their finances, and addressing legal issues. So practice restrictions. There may be some restrictions for this nurse as they transition back into total patient care. So, for example, they may have no home health work, where it might be a little bit on the easier side to get their hands on like cancer-sized prescriptions of an opioid. They won't have any multiple employers. There's limits on like shift rotation and overtime, so oftentimes these nurses will be working during the day. They won't float from unit to unit, and no access for at least 12 months to controlled drugs. So because of that neuroplasticity, we are supposed to be enabling each other for the better good here. So here's something. Health professionals have a right and obligation to ask for help when they're struggling with impairment. When they request assistance, they deserve the same care and respect that they give their own patients and clients every day. I thought that was kind of nice to hear that we deserve the best care that we can give to ourselves. Okay, one last section. We're going to talk a bit about alcoholism and the nursing care of the patient with alcoholism. Some stats I'll have you guys kind of look over on your own, but basically, as a pattern, alcohol use disorder is a pattern of alcohol use that involves problems controlling your drinking, being preoccupied with alcohol, continuing to use alcohol even when it causes problems, having to drink more to get the same effect, or having withdrawal symptoms when you rapidly decrease or stop taking that. So highly used, and lots of sequelae with that, including fatalities, fatal driving accidents, and like binge drinking, especially among our younger population. One thing that you might ask to assess alcoholism is what they call this CAGE score, and definitely if they have a total score of all 4 of those, we can most certainly send them to the proper authorities for prescriptions or for therapy and treatment for these guys. So that is one thing that you can ask a patient, is this CAGE score. C stands for cut. Have you ever felt you should cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about your drinking? And have you ever had to have a drink the first thing in the morning? So this is kind of a quick and dirty way of assessing a patient about their alcohol use and how they feel they stand on it and how they actually kind of stand on it. And once again, it's not an addiction or substance use disorder unless it has all of these things that are within our DSM-5. Lots of complications with alcoholism, tons and tons and tons, and I wish we had more time for all of this. But basically, we have our peripheral neuropathy. And that can be due to a nutrient malabsorption. We have malabsorption problems. We also have just kind of not eating problems. So a lot of alcoholics, they drink their calories, so they're just flat out not getting any kind of nutrients, and then what they are getting is poorly absorbed there. So a person can have alcoholic myopathy. This is like that wasting of the skeletal muscles, and that's due to a vitamin B deficiency. Wernicke-Korsakoff syndrome includes paralysis of the ocular muscles, diplopia or double vision, ataxia or impaired balance, somnolence and stupor, and this is once again caused by a thiamine deficiency, and this can go on to be fatal. The patient may also have esophagitis or gastritis, and this is because the alcohol has a toxic effect on that gastric mucosa there. Pancreatitis, cause of this one isn't really well known, but it's thought that alcohol decreases the efficiency of the pancreatic cells. So you guys will see a lot in your time of pancreatitis, and it can get really serious really quick, and can even be fatal. Then a patient will have cirrhosis of the liver, and that's caused from destruction of liver cells. So cirrhosis kind of means scarring. So they build up this scar tissue. Lots of problems with this, including portal hypertension or hypertension in that portal vein. There are ascites, which is those big old vessels in our esophagus, and those can Oh, excuse me, that's varices. Ascites is our extra fluid space in our abdomen, extracellular fluid. Excuse me, esophageal varices. I skipped over myself. Excuse me. Those are those big old veins that can get enlarged in our esophagus, and once those start to bleed, we have some serious problems because they're big old veins, and a person can bleed out quite swiftly there. And then a person can also have hepatic encephalopathy due to this liver cirrhosis there. Some lab values that you might see if you're looking at a patient with an alcoholic liver disease. So we have our AST, or aspartate aminotransferase. And with our alcoholic liver disease patient, that'll be 2 to 7-fold. Our ALT is our alanine aminotransferase, and this is found in the liver specifically, and that's 2 to 5-fold in our alcoholic patient. And then the ratio will be skewed because of its effect on the liver there. Our gamma glutyl transferase, or GGT, it's thought to transport amino acids. It's kind of like a catalyst for that, and it will be moderately increased, though it's really kind of non-specific. The serum bilirubin, or our ability to break down our used up red blood cells, will go away due to our liver dysfunction, and our bilirubin will be high. In fact, you might see a person kind of turn yellow because of this high bilirubin. And then our serum albumin, which is created in the liver, will be on the low side, and that's what's going to go ahead and cause the ascites there. So the patient won't have the ability to basically keep their fluid into the cell, or the intracellular space. So it'll go extracellular and end up in our interstitial space, and that's when we get that ascites. Clinical picture of this. I'll have you take a look at this slide independently. So a little bit more about the treatment of alcoholism, and I think I spoke wrong when I was up in the substance abuse lecture, so I'll redeem myself here. The acute withdrawal of seizures, or delirium tremens, is managed by the carbamazepine or benzodiazepines, such as lorazepam or Librium. And carbamazepine is actually a anti-seizure drug, but it does help a little bit on that GABA receptor site, just like our benzos do. And then we can use an IM injection of naltrexone. That's that long-acting agonist. And same with the nalmefene. Acamprosite also works on that GABA receptor there. It is safe in the liver, which is important because we do have some liver cirrhosis with these patients oftentimes. So they'll need something that is metabolically safe in the liver there. And then they have disulfiram. This isn't widely used. This is what I think I misspoke about. But it basically inhibits the acetyl dehydrogenase, which causes that hangover effect when we consume any alcohol. So a couple of nursing considerations I'll have you guys go over in your on your own. Maybe we'll go over them in class there. Some therapies for these guys that are adjunct to the medications used. Pure group therapy. These have been highly known to be very effective, such as Alcoholics Anonymous. There's also family therapy, cognitive behavioral therapy, and some people have even found that hypnotism works for these guys. So here's something that you might come up with as well, and I'll have you guys think about what you might do next. And once again with this. All right, we are done with this lengthy lecture.